She's going to take on. Yes, thank you so much. Uh, just so we know, just for privacy reasons, this program is recorded and it will be placed on our website and everywhere, just for people to be able to watch it. Somebody just called me a few minutes ago saying, oh, I'm going to be joining very late. Please, I hope it's recorded. So that's the whole purpose of the recording, nothing else. There's no other reason why we're recording it. That's why we're recording it. Okay. So we're going to go ahead now. We do have two speakers today and two other speakers who are survivors. So I'm going to introduce the two speakers first, just because I want us to be familiar with them so that we won't have a break. I would just we'll just switch from kind of one person to the other. We do have both Dr. Fajite and Dr. Ezefe. So I want to introduce Dr. Ezefe for, I'm just going to, she's been here a couple of times too. So Dr. Doreen Ezefe is a staff medical oncologist at the Tom Baker Cancer Center here in Calgary. She completed her medical degree at the University of Toronto. She did her internal medicine and medical oncology residency training in Calgary, followed by a thoracic oncology fellowship at Princess Margaret Cancer Center and a Master's of Science in Health Technology Assessment and Health Services Research at the University of Toronto. She's a fellow of the Royal College of Physicians of Canada in internal medicine and medical oncology. Dr. Doreen's research focuses on career drug access, drug funding, and assessing the value of new cancer treatments. She's a recipient of some prestigious awards. Her resume is something else. For her important research, including the Novartis Oncology Young Canadian Investigator Award, Canadian Association of Medical Oncologists Fellowship Award, and she's received peer-reviewed grant funding from CIHR and Bada Cancer Foundation and Cancer Care here in Ontario. So you'll be listening to her. I always love to listen to her. I've listened to a lot of the things that she had to share. I always love to hear her because she doesn't just have the experience. I think she has the passion. So be attentive. She's here today. I'm also going to introduce Dr. Roberts. Dr. Itope Roberts Fajita is a physician also. She has expertise in women's health. And we know that even though breast cancer is not just a women's issue, but more women have breast cancer. So she's an expert in women's health and primary care research. She's a clinical lecturer at the University of Calgary here in Alberta. She holds membership of the Royal College of General Practitioners in UK. She holds a certification of the College of Family Physicians of Canada. She's the CEO of Chat with Dr. T, a platform aimed at promoting the health and well-being of middle-aged and older women. She's the executive director of Oasis Gifting Foundation, a charity that supports the less privileged with health and educational services. She's very passionate about mentoring young girls as they navigate their personal and professional career path. Dr. Itope Fajita is intentional about using her personal life story and journey to encourage African women navigating life challenges. She speaks on topics such as the social cultural beliefs and practical practices around marriage, divorce, abuse, single parenting, ability to overcome these challenges as women. And this also informed her writing of a personal memoir titled Still I Rise, a story of 3 generations of victorious African women. Dr. Itope is an entrepreneur, a collaborator, and other women are passionate about making a difference in the world. She encourages other women to become more purpose-driven, passionate about achieving and making an impact in their personal lives and community, wherever you find yourselves. She's married to Mr. Gilbert Fajita, and they have 3 children. So I'm gonna leave it at this. I would later introduce Auntie Yinka and Mrs. O'Mara, but I want us to go straight to Dr. Fajita now. If she has, Dr. Fajita, I want us to go through to you. Thank you for coming. Thank you for honoring
this.
Thank you
so much. Not
please
a problem.
Yeah, please go ahead. You have 25 minutes.
Okay, right. Can everybody see my slide?
Yes, we can.
Awesome. Good afternoon, everybody. And I'm really honored to be invited to give a short talk about breast cancer. I'm going to be focusing on signs and symptoms. Thanks for that long introduction. I think I need to make my resume a little shorter. It's quite a mouthful, but really thanks to all the women that have made time to come here today to discuss this extremely important topic. And I'm just going to go ahead and talk about mine. So there's, without any further ado, I'm going to be talking about breast cancer signs, symptoms, and a lot more. So breast cancer, how do we define it? So are you seeing my full slide, please? No, this feels so, okay, this is better. Am I right?
Yes.
But then this is disturbing me a little bit. Okay, great. So what is breast cancer? We start off with the definition, and breast cancer, just like any other cancer, happens when normal cells within the breast become abnormal, they start to multiply, and they grow out of control. So there are different types of breast cancers, and I'm so glad the lady that introduced us talked about breast cancer, not just Mrs. Olajusu, talking about breast cancer not just being a disease of women. So wherever you have breast tissue, you can have breast cancer. So men can also develop breast cancer. Of course, today the focus is on women. There are different types of breast cancers. Most of the time, they can either start from the ducts of the breast, the lobules of the breast, or the connective tissue or tissues surrounding the breast. So what are the common signs and symptoms? So symptoms usually is what the patient feels or what the patient presents with, and signs could be either confirmed by the doctor or by imaging. The most common finding is that of a breast lump or thickening that feels different from what a woman would normally experience. Sometimes there's a change in the shape or the appearance of the breast. One may find that one breast looks a little more deformed than the other. Sometimes the changes are just limited to the skin of the breast, where people have what we call dimpling. So if you imagine having like a pulling, so part of the breast appears pulled in compared to the rest of the breast. Most women will have nipples that pop outwards, what we call everted nipples. Some women are actually born with inverted nipples, which are nipples that point inwards. But if, for example, you've always had nipples that point outward, and for some reason on one breast, you find one nipple is pointing inwards compared to the other, it's what we call an inverted nipple. And even though there are other reasons, breast cancer is one of the main things we need to exclude if a patient finds that a nipple becomes inverted. Oftentimes, the symptom of breast cancer is not just about lump, it could be actually restricted to the overlying skin. So some women may discover that they have peeling, scaling, crusting, or a rash around the darker part surrounding the nipple called the areola that kind of is like a rash. Sometimes it's a little, it just doesn't go away. People will try and put different creams and it's not going away. There's a particular type of breast cancer called Paget's disease of the breast that can present this way. So if a woman has a rash around the darker area surrounding the nipple called the areola that's not going away, you need to see your doctor and get assessed. Another thing some women may find is redness or pitting of the skin over your breast. Oftentimes like the skin of an unpeeled orange, something we call pulled orange. So you find that the skin of the breast just almost looks like the back of an orange that has not been peeled. Now, since I've been practicing abroad, which is going over 20 years now, I've never really found women with constitutional symptoms. But I remember back home in the 90s, when I was in medical school and where people would normally not present, some people actually present with very advanced breast cancer. And this will be breast cancer that has spread or metastasized to other organs. And oftentimes these women may have other symptoms like feeling tired all the time, losing weight, you know, very anemic, not just really fatigued. And oftentimes by the time breast cancer presents this way, it is pretty advanced. So before I talk about detection, I wanted to talk about causes. This is one of the bit of a difficulty for doctors. It's not all the time that we always have a cause for breast cancer. Of course, a woman or a patient with a family history of breast cancer, depending on what type of breast cancer and the relative that is involved, for example, if it's a first-degree relative like a mother or sister, that might make the patient to be more at risk of developing breast cancer. So there are genetic factors, there are hormonal factors, there are lifestyle factors. Sometimes it's a combination of these, and sometimes we don't even know why people develop breast cancer. In my practice, I have patients come in and say, you know, I don't want to get a mammogram because nobody in my family has breast cancer. So the fact that no one in your family has breast cancer does not imply that a patient may not develop breast cancer. So it's really important that we're really up to date and we're really very aware that we still need to do the right things to detect breast cancer, which takes me to my next slide about detection. The best way to detect breast cancer is to detect it early. And the best way to detect it early is to go for what we call screening, mammograms or automated whole breast ultrasound, which is what AWBU stands for. Now, the reason why we do automated whole breast ultrasounds, and some women, especially women of African descent, may have more dense breasts. And if we just use the plain simple X-ray of the breast or special X-ray of the breast called the mammogram, we may miss some lesions. Therefore, we go ahead and we do the ultrasound in addition to the mammogram. Sometimes this is the best way to discover very early changes within the breast, which sometimes a patient may not even be able to palpate or feel by themselves. Some patients are able to detect a lump, and I'm going to be talking about self-breast exams later on in the presentation. So sometimes the patient is able to, because as women, we should know what our breasts feel like. So some patients will present because, you know, they're in the shower, they're washing, and they feel something different in their breast, and it stays there. They feel a lump, they come to the doctor. Now, not all lumps in the breast are breast cancers, but every lump that is felt in the breast of any woman should be, you know, examined or seen by a family doctor, and we will now, or any doctor for that matter, and we will now go ahead and investigate to find out what this lump is. So please don't always panic. Sometimes lumps could be cysts, sometimes they could just be fibroadenomas, which are very benign breast lumps, but definitely we want to exclude breast cancer. The other thing is breast awareness, and I was just talking about this earlier. Every woman should know what their breast feels like. It's okay to feel your breasts once in a while. Now, for those women that still have their cycles, I recommend checking your breast after your menstrual cycle, because some women have lumpier breasts before their cycle. So you might feel that you're feeling a lot of lumps, but it's best to just wait till after your period, have a good feel of your breast, not because you're trying to make a diagnosis, but because you're trying to know what's normal for you. So that if you ever get to a point where you're feeling your breast and something feels out of place, you will know, because you know what your baseline breast exam, or when you do feel your breast, what that feels like. So I'm not going to overflow that. We're going to get to that. Just a quick note here. Breast awareness, or knowing what your breast feels like, does not prevent breast cancer. It just helps you to better understand what your breast feels like. You're able to identify any unusual lumps or bumps, and you're able to report that. So don't say, well, I feel my breast all the time, I don't feel anything, so everything is fine. I know I don't have cancer. It's a lot more than that. So I'm just going to talk about some other vital points as far as our breast health is concerned as women. And the first thing to talk about is screening. Now in Alberta, where most of us live and work, screening is available to every woman aged 40 and above. So from the age of 40, your family physician should be offering you a mammogram, and we will normally offer that a mammogram and breast ultrasound that I talked about earlier to have a full assessment of your breast to be sure that everything is good. Sometimes they pick up a spot, a lump, an area of cluster, a lymph gland, and the radiologist will decide if you need to come back in 6 months or 1 year intervals to get further testing to monitor that lump. But that's the best way to make sure that we're keeping an eye on things and we're doing our own due diligence so that early lesions within the breast can be identified and managed appropriately. So from the ages of 40 to 50, mammograms are done every year in Alberta. And after the age of 50, they're done every 2 years. Now, sometimes we continue screening every 2 years until patients are in their early 70s. Now, sometimes it's also individualized. For example, in a family history of cancer or personal history of cancer, the screening interval might change. So it might not be every 2 years if you're over 50 or 40 to 50 yearly. It really depends. Now, people that have had previous cancer diagnoses may need to have, irrespective of their ages, annual breast exams or mammograms if they haven't had the whole breast removed. Now, other tests, some women go, I don't want a mammogram, I don't want an ultrasound, I want to get an MRI because an MRI is the best. Now, there is a place for breast MRIs, but usually we get a lot of false positives if it's used as screening. So sometimes for very high-risk patients, there is a place for breast MRIs. But usually for our day-to-day screening and evaluation for breast cancers, we do not need MRIs or magnetic resonance imaging. The other thing to talk about quickly is breast exam. So remember I talked about self-breast awareness, knowing what it is. So the important thing is to know what's normal for you. And most women will say, how do I do it? I don't understand it. Now, first, the timing after your period, if you are still menstruating. If you are not, pick a time every last Sunday of the month or first Sunday, whatever is good for you, to have a feel of your breast, either in the shower or in front of your mirror. You want to raise your hand up, just like this lady. The key thing is you want to go around every single area of your breast without leaving anywhere out. Now, you can do this by dividing your breast into little quadrants, as in this diagram, or sometimes you can actually go round and round the nipple, right from the middle all the way outwards to the exterior, the outside of your breast, close to your chest wall. Sometimes what I learned in medical school is to draw an imaginary line top to bottom across your nipple and side to side across your nipple as well. So that divides your breast into 4 areas. And you want to use the flat of your hand to feel every area of your breast. So whichever method you choose, the key thing is don't leave any part of your breast out when you do this examination. And again, it just tells you what your breast feels like. So that if first Sunday of the month you go ahead to examine and you say, I didn't feel this last month, then it's time to make an appointment to see your doctor. Now, is there any way we can prevent breast cancer? You know, I talked about family history, which unfortunately can put people at risk, but are there things that we can do to reduce our risk of breast cancers or even other cancers in general? And I'm just going to share a few of that. First of all is to limit our alcohol intake. We want to exercise most days of the week. And what is recommended is 30 minutes of moderate exercises 5 days a week at a minimum to maintain a healthy weight. So if you find your body mass index, which is a fraction of your weight divided by the square of your height, is more than 30, you're overweight. More than 30, you're obese. Is more than 25, you're overweight. So it's very important that we keep an eye on our weight, and if we have those extra pounds, to start to work on them. Talk to your doctor, talk to a dietitian, talk to a nurse, and make sure you're shedding all the extra pounds. Choose a healthy diet. You know, it's found that women that eat a Mediterranean diet supplemented with extra virgin oil, mixed nuts, can have a reduced risk of breast cancer. you know, and this is a plant-based diet, and there's a bit of research around that. Now, postmenopausal hormone therapy in certain women that may be at risk can actually push them into developing breast cancer. It's very important to have discussions with your doctors before you start any kind of hormone replacement. I mean, these days when you can get almost anything online, I will always strongly recommend, if we're going the hormone replacement way, you should please be talking to a doctor. There are studies to show that breastfeeding can be protective against breast cancer. In summary, today I've talked about the definition of breast cancer, what it is, when normal cells of the breast start to multiply abnormally and patient may develop a lump or changes that may get bad. That means it might metastasize, it might move beyond the breast to affect other tissues and other areas of the body. Something I didn't mention is that with the improvement in technology, with screening, breast cancer is no longer a death diagnosis. Because we are detecting it early, there is good treatment. The mortality or death rate from breast cancer is really declining. And I know it can be extremely frightening. My youngest patient with breast cancer was 29 years old, you know, and she's doing excellently well now. So it can be really scary, but just for women to know that there is support out there. There are people to help you. Our systems, Mrs. Oladile was just talking about the foundation. So there's a lot of support out there. There's survivors that are more than willing to share their stories, just so women know that they're not alone. It can be really scary when you first hear, or even when you feel it long. But like I said, it's never the end of the world. Even if it's the worst case scenario, breast cancer, there is treatment. And that's why we really need to be very breast aware, make sure we're talking to our doctors, make sure we're getting our screening done. I've also talked about signs and symptoms of breast cancer. I've talked about the filling up of a lump and the importance of getting your screening mammograms, automated whole breast ultrasounds for evaluation or screening for early lesions of breast cancer. I've also talked briefly about prevention, or a few things that we can do to make sure we're staying healthy and protected from breast cancer. I want to thank you all for listening, and hope you enjoy the rest of today's talk. Thank you. Have a wonderful day. Thanks.
Thank you so much. That was awesome. Thank you so much you kept your time and you were just on point. Thank you so much for that. Of course, we're here today because there are survivors too. I'm a breast cancer survivor, and exactly what she said is actually what happened to me. I'm one that usually do checks on myself. That day though, I don't know, I think it's the Holy Spirit or something that just made me check. And I went to the hospital right away. I went to see the doctor right away, and I was told to go do a mammogram, ultrasound, and none of that picked it. I'm saying that because she talked about knowing your breast. You need to know your breast. So you need to know your body as a woman. And that was one of the things God used to save me, because at the end of the day, in fact, they said I didn't have anything. They did mammogram, they did ultrasound, and they asked me to go. I was actually on my way out, and they called me back to do, and because I kept saying, but I can feel something. I felt something, even though it was little. So you do need to know your breast. Thank you so much for that. We're gonna go straight on now to Dr. Ezeife. Are you there, Dr. Ezeife? Are you there, ma'am?
Yes, I'm here. Sorry, I was just trying to get to a new room.
That's okay. Thank you so much. Take your time. Are you ready though?
I am.
Okay, so I'm gonna give you 25 minutes. It's 4:30. It's 4:35 now. So I'll give you 25 minutes if you don't mind. And we'll take it from here. Thank you so much. Go ahead. You can share your screen.
Excellent.
Just before you go ahead, if you do have any questions, we're gonna have a Q&A session shortly. Please send in your questions. You can put it on the chat, whatever works for you. Thank you. Go ahead, Dr. Ezeife.
Excellent. Can you see my slides? Hello?
Yes.
Perfect, excellent. Okay, so,
Yes, we can see.
okay, great. It's nice to be here. Thank you for inviting me. And Dr. Fagite, thank you for that wonderful talk. That was excellent. I'll be talking a bit more about once you get diagnosed with breast cancer and you start going through the journey and what the treatment looks like, what the side effects of treatment are, and then any questions that you may have from there. So Dr. Fagite did an excellent job of talking about the signs and the symptoms. I don't think I'll have much more to add, but we'll go through my slides. And then I'll talk about the diagnosis, what that looks like. And then we'll go into the management. And then after you get through the management of the disease, go through treatment, what the surveillance looks like after, once you move into that survivorship period of life. So Dr. Fagite elegantly explained this. And cancer is really when you have normal cells that have aberrant growth. So they often undergo gene changes that allow them to grow uncontrollably. They keep dividing, they never really mature, whereas normal cells will get to a stage where they mature and they die off, but cancer cells don't have that issue because they have unregulated growth. They never really serve a function. They don't die when they're supposed to, and they don't respect other tissues or other tissue spaces. So they grow uncontrollably, and that's how you develop a tumor because of this aberrant growth. And the symptoms happen because of this mass effect when you develop an accumulation of cancer cells. This mass of cancer cells starts to disrupt the way the normal organ functions. In this case, as Dr. Fagite lovely mentioned, it's usually in the breast duct, most commonly, although it can be anywhere else in the breast. It starts to disrupt the way that breast duct normally functions and develops. And that's how you develop a mass and therefore a tumor. So the signs or symptoms of breast cancer, as we previously discussed, will be a lump, the pain. Dr. Fagite mentioned this peau d'orange change, and this is what we can see in the picture here. It kind of looks like the skin of an orange. And I actually see this very commonly in breast cancer patients. There's this dimpling that occurs, and the skin looks very smooth and shiny. And that's not always the presentation, but that is one presentation that we can sometimes see. There can sometimes be nipple discharge or ulceration or bleeding, indentation of the nipple. These are some of the presentations that we can see. And of course, we talked a little bit about constitutional symptoms. And these can happen when the breast cancer has spread to an advanced stage. Usually it starts in the breast, and if it spreads outside to other organs, and this is when we can have other symptoms. So if there's a headache, that can be due to spread of breast cancer to the brain. If there are enlarged lymph nodes, usually in the armpit on the same side as the breast tumor, that will be the first place typically. And that's due to spread of breast cancer to the lymph nodes. There can be muscle or bone pain due to spread of breast cancer to these areas. And then one generalized symptom that we see very commonly is fatigue. And that's because the breast cancer will secrete some nasty proteins that cause the body to feel very fatigued. Other constitutional symptoms can include nausea, weight loss, or cancer cachexia is what we call it. Those are some other constitutional symptoms. So the history. So now we're moving into the diagnosis. So when somebody has these symptoms that we talked about and they go and see their doctor, then the doctor will take a history where they'll ask you kind of in a systematic way about other different symptoms that you're having. And that will help them to kind of get a sense as to what the level of risk is. Now, there are some patients who are already at risk of breast cancer. And Dr. Fagite mentioned this family history. So some people can have a genetic predisposition. I think we may have all heard about BRCA1 or BRCA2, and these are genes that all of us have. And in some cases, they may have a change in them or a mutation that predisposes someone to having breast cancer because of that mutation or that change in those genes. There are other familial genetic mutations that can happen, but I think BRCA1 and BRCA2 are the most common that many of us would have heard about. I always tell patients that age is the biggest risk factor for breast cancer. For any cancer, advanced age is certainly the biggest risk factor. I mean, 1 in 8 of us will get breast cancer. And a big reason for that is because many of us are living for longer now than we ever did, 20, 30, 40, 50 years ago. And so this advanced age is certainly a risk factor, and we have a higher risk of getting cancer the older we get. So these lifestyle factors are certainly important, as Dr. Fagite mentioned. Exercise has been shown to reduce the risk of breast cancer. So certainly I completely agree with exercising. Even any level of exercise, just moving the body is important. If we can't all hit that, 90 minutes of exercise a day, or, the 150 minutes of exercise a week, it's important to just try and move, whether it's walking, stationary bike, yoga, Pilates, whatever we can do. Certainly limiting smoking. Alcohol has been linked to 7 different types of cancers. And it's a dose response relationship, which means that even a little bit of alcohol has been associated with some risk of cancer. So I really try and counsel my patients to limit alcohol intake if we can. I know we were considering all of these things, and it's important to try and enjoy life, but these are just some ways to make some lifestyle modifications. And then, so after the doctor asks some questions and takes a family history and all these things, then the doctor will move into the physical exam. And we all kind of know that a physical exam is when the doctor examines you and gets a sense of what the concern is. So this is a picture of the breast. And sometimes it's nice just to get a sense of the anatomy before we start talking about different treatments. So we have the 2 breasts here, and then these structures here are the lymph glands. Can people see my arrows when I move the arrow? Is that visible? Okay, perfect.
Yes.
Yeah. So okay, perfect. So the first place that a breast tumor will spread to once it starts to spread is to these lymph chains. And the lymph chains are the first in the armpits or the axilla. And there's 2 kind of regions here. So there's one that's a bit more closer to the skin or superficial, and these 2 areas here. And then there's the level 2, or this ones that are a bit deeper in, and then there's level 3, which are the next ones that are deeper in. And we have, thousands of lymph nodes all throughout our body. And these are the lymph chains where the breasts will drain to. So when you go and see the doctor and they're examining you, they'll do a pretty deep exam, okay? So first they'll feel kind of along the side of the breast here, which we can feel ourselves, and in the corner of the armpit here. And then they'll do a really deep exam into what we call the apex, or the deep corner of the armpit. And they can even try and feel into these level 3 lymph nodes into the deep corner there. So that's when the doctor does that, that's when they're doing a proper exam. And, I keep my nails short. I can't wear those long Cardi B nails that all the young girls are wearing, because I do these exams on hundreds of women in a week. And you really have to do a lot of digging. You have to go right in there in order to be able to do a proper exam. And that's just because of the anatomy, or the way the lymph nodes drain in the breast. Breast cancer can also drain into the lymph nodes along the breastbone, or the sternum bone. And these lymph chains here, the internal mammary lymph chains. And rarely, when it spreads even farther, it can drain to the lymph nodes in the at the top of the neck, so, or the supraclavicular and infraclavicular, just above and below the collarbone there. So these are kind of the areas where you'll see your doctor feeling around once they do the breast exam, and they'll start feeling around these areas to do a full exam of the breast. And then, as Dr. Fagite discussed, then they will do a mammogram and ultrasound. Usually the mammogram and ultrasound are quite good at detecting any areas of concern. And once there's an area of concern detected, you know, the Alberta system is actually very quick. It's very streamlined, because the same day the patient will be organized for a biopsy, and the biopsy will happen within days. Like, I'm quite impressed when I see these patients. They have everything go very quickly, and hopefully COVID hasn't slowed that down too much. But a biopsy will be done. And biopsy, after that, something called a sentinel lymph node biopsy will be done. And that's when the lymph nodes in the armpit are dyed by the surgeon. They inject a dye, and the dye will go to wherever the breast tumor is draining into the certain lymph node. If the breast tumor is spreading to that lymph node, then the dye will spread, then the dye will show up on that lymph node, so it will be positive. If the breast tumor is not draining into that lymph node, then the dye will not show up on that lymph node, so the lymph node will be negative. So that's how they get a sense as to whether that breast tumor is spreading to the lymph node or not. In patients who have lymph node positive breast cancer, meaning that there's confirmation that the breast cancer has spread to the lymph node, then we do a CT scan and a bone scan to ensure that the breast cancer has not spread to other areas of the body. So our standard is typically do a CT scan of the chest, abdomen, and pelvis, which means a CT of the chest and the belly. And that looks to see whether the breast cancer has spread anywhere else, whether it's the lungs, livers, bowels, kidneys, anywhere else in the body. And then a bone scan obviously checks to see whether the breast cancer has spread to the bone. So that CT and bone scan is only done if there's lymph node positive breast cancer. It's not done for breast cancer that has not spread to the lymph nodes, because it's considered so low risk and unlikely for the breast cancer to have spread anywhere else if it has not spread to the lymph nodes. So there are different types of breast cancer, and we may have heard about these before, but let me go over them now. There are 4 types. The first type is something called luminal A. The second type is luminal B. And then there's HER2, and then there's triple negative breast cancer. So in the general population, this is the frequency of these different types of breast cancer. Luminal A is by far the most common, luminal A and luminal B. And these are the breast cancers that are a bit more indolent, a bit more slow growing. They are ER and PR positive, which means estrogen and progesterone receptor positive. This means that breast estrogen acts as food for the type of breast cancer. So these are the most common types of breast cancer in the general population, or I would say in the Caucasian population. In Africans, triple negative breast cancer is actually the most common. So 60% of breast cancers diagnosed in African women and men are triple negative, okay? So it's actually quite different from what we hear in the general population. So it's very important to note these statistics, because triple negative breast cancer can be more aggressive. It can reoccur soon after the early stage breast cancer is treated. So the signs and symptoms must be watched out for. The next most common type of breast cancer in Africans is the luminal A and luminal B subtypes. And again, these are the estrogen and progesterone receptor positive types of breast cancer that tend to be a better prognosis, slower growing, and more indolent disease. And then the last type of breast cancer that's seen in Africans is something called HER2 positive breast cancer. And HER2 is a protein that breast cancers make. And it's a protein that we don't like to see. As an oncologist, I don't really like to see HER2 protein because it predicts a breast cancer that behaves a little bit more aggressively. But there has been a lot of research in the last 5 to 10 years that now we have anti-HER2 therapy that has certainly improved the survival for HER2 positive breast cancer. So we've been very pleased about that because it's increased cure rates tremendously. And we've seen a lot of great outcomes because of this anti-HER2 protein. So what are the goals of cancer therapy? I mean, I think that's a question where some people may think there's such a simple answer, but they're actually, it's actually a bit more complex than that. So the first one that most people would think of right away is that we are trying to cure patients with a life-threatening illness. And this is certainly very possible in people whose breast cancer is localized, that has not spread outside of where it first started. The goal certainly is to cure it, and to allow patients to live well during their treatment and into that survivorship period of life. The next goal is to provide therapy which can prolong life with good quality if cure is not believed to be possible. And cure is not always possible in people who have stage 4 disease or disease where the breast cancer has spread outside of where it first started. In those cases, we're not able to cure the breast cancer yet, meaning we can't make it go away completely, but we certainly can treat it. And the goals of treatment are to prolong life and improve quality of life. And lastly, another goal of cancer treatment is to minimize the trauma of a cancer diagnosis on the patient and their family. It can certainly be a lot having a cancer diagnosis and going through treatment. So another goal that we focus on is to help minimize the harm of our treatments and all of the sequelae of the treatments. So what does a treatment look like? I would say that there are 5 categories. So the first is surgery, and the surgery can either be a lumpectomy or a mastectomy. So in this picture I've shown here, this is a woman who has had double mastectomies done. So mastectomy is when the entire breast is removed. The surgeon removes all of the breast tissue, so there's no remaining breast tissue. Some patients choose to have a mastectomy, and some patients even choose to have the mastectomy and the affected breast and a prophylactic mastectomy in the other breast, meaning they choose to just have all of the breasts removed, both breasts removed, because they don't want to have to worry about getting contralateral or breast cancer in the other breast. Lumpectomy is when patients choose to conserve the breast tissue. So they choose to just have the tumor removed. So what the surgeon will do is they'll remove the tumor and they'll usually have a buffer zone. So they'll remove some an area of normal tissue around that to ensure that all the margins are negative and they remove all of the tumor. There's no worry about leaving any cancer behind. And now getting into the drug treatments. So one category of drug treatments is something called endocrine therapy or anti-hormonal therapy. And we would have all heard these drugs before, whether from friends and family who have gone through the disease or ourselves personally. But tamoxifen, we typically use in women who are still menstruating. So women who are premenopausal, we use tamoxifen. And then the drugs that we use in women who are have gone through menopause and they're postmenopausal, no longer having our periods, these drugs are called anastrozole or letrozole. In young women with stage 2 or stage 3 breast cancer, or breast cancer that's considered to be something that we would have treated with chemotherapy or considered to be a bit higher risk, we also add a drug called Lupron. And Lupron is a hormone that puts a woman's body into menopause. And we do that so that we can treat these women with anastrozole or letrozole. And that's been shown to have better outcomes to put a woman's body into menopause, especially if they've had that luminal A or luminal B type of breast cancer, where estrogen was acting as fuel or food for their breast cancer. What this Lupron drug does is it helps to shut off the body's response to estrogen so that estrogen no longer acts as food for potential breast cancer regrowth. So this is our standard now in young women with higher risk breast cancer, is we put their body into menopause so that we can treat them with anastrozole or letrozole. Another drug that some women may be on is something called exemestane, and that's similar to anastrozole or letrozole. And then chemotherapy. And chemotherapy is recommended in some patients where the breast cancer has spread to the lymph nodes, or even in women where there's no spread to the lymph nodes, but is considered higher risk. So we use chemotherapy to lower the chances of the breast cancer coming back. Radiation therapy is also used. So the reason for doing radiation therapy is to lower the chances of the breast cancer coming back in the breast or in the armpits. And we recommend radiation therapy for every woman who has had a lumpectomy, or if the lymph nodes are involved, then we recommend radiation therapy. And I have some patients come and see me and they tell me that when they saw the surgeon, because usually what happens first is, you have either you feel an abnormality in your breast, or you have your screening mammogram that detects an abnormality, and then you go see your family doctor, and your family doctor feels the lump and then sends you for an ultrasound or mammogram that confirms an abnormality, and then you're sent for a biopsy. Once the biopsy comes back showing breast cancer, then your family doctor will refer you to a surgeon. So usually the patient's first point of contact with the oncologic system is a surgical oncologist. So the patients will see a surgeon first, and a surgeon will speak to them about either a lumpectomy or a mastectomy. And sometimes it's missed in the conversation. And I have some patients see me as the medical oncologist who they meet down the road after they've already had the surgery. And they tell me that they were never told that they will need radiation if they have a lumpectomy. So I think that's an important point to make here, is that if you're trying to decide the decision between should I have a lumpectomy or a mastectomy, a lumpectomy is plus radiation. You have to have radiation if you have a lumpectomy. A mastectomy, you may avoid radiation if the lymph nodes are not involved. If the lymph nodes are involved, then you will need radiation even if you have a mastectomy. Bisphosphonates are a type of drug that we now use for breast cancer as well. We know that adding bisphosphonates helps to improve the cure rates. So we offer bisphosphonates for women, again, who have had higher risk breast cancer. And it's an injection, this Zometa drug. It's an injection that's given every 6 months for 3 years. And that's really another tool in our toolbox to improve cure rates for breast cancer. As I said before, breast cancer affects 1 in 8 of us, but the cure rates are so good. And many of us, will move into that survivor period and will never have to deal with it ever again. And that's really because of all these ways that we have to attack it to lower the chances of it coming back and improve those cure rates. So just to get into the drug treatments a little bit more, because this is, what I do. There are different types, as we mentioned, chemotherapy and endocrine therapy. So your next question may be, well, who gets what treatment? And that really depends on what type, without getting too much into the nitty gritty of things and into the weeds of it. The general categories are that triple negative breast cancer is generally treated with chemotherapy after the surgery. Luminal A and luminal B breast cancer. So for luminal A, endocrine therapy or anti-hormonal therapy is the main way to treat this for the majority of cases. Sometimes if there's lymph node involvement, then chemotherapy is needed. For luminal B breast cancer, and this is for breast cancer that are either ER positive and PR negative, or vice versa, so ER negative and PR positive, or they're higher grade tumors. Then these patients often get chemotherapy plus or minus endocrine therapy, depending on whether the lymph nodes are involved. HER2 positive breast cancer, the main treatment for this is chemotherapy accompanied with an anti-HER2 therapy. And anti-HER2 therapy is a drug that's given with the chemotherapy, and it's given every 3 weeks for up to a year for early stage breast cancer. So what are the side effects of treatment? I separated these into surgical side effects, chemotherapy side effects, and radiation side effects. The surgical side effects, most people actually do quite well with surgery. It tends to be a day procedure. A lot of my patients, tell me that they were discharged the same day and they go home. There are the small subset of people who have some complications, but the majority of people do well after surgery. Some side effects I hear very commonly can be breast pain, numbness, and tingling. The numbness and tingling is because when the surgery happens and they remove the breast tissue, the nerves are run right around that same area, right underneath that our pecs or our pectoralis muscle where the breast is on top of. And so inevitably, the nerves are damaged with the surgery. And it takes nerves time to regrow. It can take 6 to 12 months for our nerves to regrow. And while they're regrowing, there can be a lot of sharp pinches and twinges that happen. So it's very normal to feel some numbness and tingling over those next 6 to 12 months after the surgery as the nerves regrow and heal. Lymphedema is a very common side effect after surgery. It used to be much more common decades ago, but with this sentinel lymph node biopsy procedure that the surgeons are now doing, where they only remove one lymph node and look to see whether that's involved with the breast cancer, the lymphedema rates are much lower. Back in the day, meaning 20 to 30 years ago, surgeons would remove all the lymph nodes in the armpit, and breast cancer patients would have a lot of swelling in the arms. And this was quite significant. In Calgary here, we have a lymphedema clinic that is very helpful. I hear such great things about the lymphedema clinic. They really help teach patients kind of what procedures, even massage techniques, warm compresses. They have compression sleeves. They just have a bunch of different techniques that they offer to help minimize the impact of lymphedema, because it can be quite bad. As with any surgery, infection and blood clots are some side effects that a subset of patients will experience, unfortunately. Now, for the chemotherapy side effects, we try to get people through the chemotherapy with drugs to help manage these side effects, but people can feel fatigued. I always tell patients that the fatigue shouldn't be so bad that they're lying in bed all day, spending all day in bed. We still want people to be up and about. And if the fatigue is that bad, then I would say that there's a problem and the doctor needs to look at reducing the doses a bit of the chemotherapy drugs. Numbness is a very common side effect of the chemotherapy drugs that we use, numbness and tingling in the fingers and toes. And I usually ask my patients about this sort of every 3 weeks or every 2 to 3 weeks when I see them, because if the numbness is getting very bad, meaning that it's constant and it's impacting the ability to do fine motor tasks like using a pen, opening up a jar, buttoning up a shirt, then that's probably to the point where the chemotherapy drugs need to be reduced. In the majority of people, this numbness will resolve after chemo is completed, but in some people it can be permanent. So we really need to watch that numbness side effect. The chemo can have this side effect of slowing the strength of the heart. So your doctor will often do a heart ultrasound or an echocardiogram before starting chemo as a baseline. And then especially in people who are receiving Herceptin, which is an anti-HER2 drug, they'll repeat that heart function test sort of every 3 months for the year that they're on Herceptin. Chemo can cause nausea. I think we're all very familiar with the nausea of chemo. But we have strong nausea medication now, so people should not be vomiting. One thing I didn't put here, obviously, is alopecia or hair loss. Chemo can cause hair loss, certainly. We do wig prescriptions and things to help with that. Bone pains. The bone pains can be quite bad. So I often have to give my patients pain medication for the duration of the time that they're on these chemo drugs. Specifically, a drug called docetaxel can cause a lot of bone pains, especially with Neupogen or Neulasta that some people are taking to help with the blood counts. Those two drugs together can cause a lot of bone pain, and often Tylenol or Advil just isn't enough to help with those bone pains. And people need something like codeine or morphine to help, maintain some quality of life. Chemo can cause low blood counts, and some people need blood transfusions while they're on chemo. I would say it's certainly the minority of people, less than 10%, require blood transfusions. And then there's this rare risk of secondary leukemia. It's a very low risk, but it's certainly something that's important, and I mention it to all my patients because it's an important thing to discuss. And that 0.5% at 10-year risk is the combined risk of a pre-leukemia or an MDS and a leukemia. So there is that small risk there, but it's important to note. Radiation can have local side effects, usually involving the skin, redness, peeling, dryness, tightness. Radiation is tough because it's every day for a duration of like 3 or 4 or 5 weeks. And that can really accumulate the side effects and make people feel quite tired as well. There's this small risk of pneumonitis or inflammation of the lungs. Most of the time when I see it, it's a very subclinical thing, or people don't have any symptoms from it. They can just, we just see it on the CT scans and the chest x-rays, but it doesn't actually need treatment or medication. But some people do need treatment with steroids to help with the breathing and the cough that develops from that. But again, that's a rare side effect. Oh, and we should know that these side effects are usually temporary for the duration of time that people are on treatment, and they tend to resolve after. So I think one of the questions when Yinka was polling for questions that I should discuss in this session, one of the questions that came up was, what does the survival look like when people have all these treatments? And we usually discuss it in terms of lymph node positivity, because lymph node positivity is the greatest indication of how the cancer is going to behave. Usually we categorize it into lymph node negative or lymph node positive. So if the breast cancer has not involved the lymph nodes, then we like to separate it into low risk or medium or high risk. And what determines whether a breast cancer is low risk lymph node negative or low risk medium or medium or high risk lymph node negative is really things like grade, whether it's ER/PR positive, HER2 positivity, the age of the patient, and the grade, meaning the way the cells look under the microscope. We know that if it's low risk, then the risk of the cancer coming back is about 10 to 20%. So it's quite low. And if the breast cancer is medium or high risk lymph node negative, then the risk of the breast cancer coming back is less than 30%, 20 to 30%. If the breast cancer has involved 1 to 3 lymph nodes, then the risk of the breast cancer coming back is about 30 to 50%. And if there are more than three lymph nodes positive, then the risk of the breast cancer coming back is about 50 to 75%. So after treatment is completed and people are moving into the survivorship period of their life, then I often go over surveillance with them. And surveillance just means, how do we observe you to make sure the breast cancer doesn't come back, or to lower the chances of it coming back? And if it does come back, how do we catch it early? And there are actually Alberta guidelines for this. The guidelines say that we should do a history and physical. So history, where you talk with the doctor and tell them how you're feeling. Physical, where the doctor examines you every 6 months for the first 2 years, and then annually after that. And then we recommend continuing on with annual mammograms, so yearly mammograms on any remaining breast tissue. So this means that if you've had mastectomies, so double mastectomies, then obviously there's no breast tissue to do mammograms on. So really the mainstay of surveillance in that scenario would be history and physical every 6 months. We actually don't recommend CTs and bone scans at any intervals for surveillance of early stage breast cancer. I get this question a lot. People ask, can I just have a CT sort of every 3 months or every year? And we don't do this because we know that the chances of the breast cancer coming back are felt to be quite low, and the radiation exposure from CT and bone scans is actually higher. We only recommend scans if there is a medical concern prompting the scan. So things like, I tell people to look out for symptoms that are not going away after 2 or more weeks, that are constant and not going away after 2 or more weeks. And if we think back to that chart that I showed earlier, things that are strange or unusual for you. So whether it's headache that's not going away, that's new for you, and that hasn't gone away for 2 or more weeks. Pain, if there's a lump that you feel on the chest wall or anywhere else. Weight loss that's unexplained, meaning you haven't been trying to lose weight, but you're losing weight inexplicably, then certainly that's something to bring up with your doctor. And that would be the scenario where your doctor would be justified to do a CT or bone scan. So, oh yes, I do have it here. So symptoms to watch out for. And this is actually on the Alberta Cancer Guidelines website. So they're very prescriptive, new masses in the breasts, then the appropriate test in that scenario would be, mammogram or ultrasound or biopsy even. If there's a new suspicious rash or nodule on the chest wall, then this should certainly be investigated further. If there's new palpable lymph nodes, so if there's an enlarged lymph node, lymph gland in the armpits or somewhere else in the body, and that should certainly be investigated by a biopsy. And then bone pains that are not going away should certainly, because we all kind of have aches and pains that come up throughout our life. Were on the treadmill for too long or lifted too many weights and you have muscle or bone pains, and that's explained. But if there's something that's not explained, that's not going away, then that's when it should be investigated further. New cough or shortness of breath, then a CT chest or a chest x-ray should be done. Or there's enlarged organs in the body, and different concerns like this should be further investigated with the appropriate test. I always find it's helpful to have some resources. I think we're inundated with information and we never know kind of what's a credible resource and what's not. So here are some resources that I direct my patients to. So I've spoken about the lymphedema clinic, and they're actually out of the Holy Cross. They have a clinic on Wednesdays. So if you're having a lot of problems with lymphedema and your doctor hasn't mentioned the lymphedema clinic to you, I would empower you to advocate for yourself to be referred to the lymphedema clinic, because a lot of my patients have had great outcomes and speak very highly of them. Breast Cancer Supportive Care Services is a nice resource that we actually have here in Alberta. They're excellent because they see breast cancer survivors. I always say that it's a strange time moving into that survivor period, because it's hard to put the breast cancer behind you. We've been through so much with the breast cancer treatment, and now we're moving into this period of trying to look at the glass half full and trying not to focus on that worry of recurrence and worry of all these different things. And we may also have side effects from the treatment, some side effects that are taking some time to dissipate. The breast cancer supportive care services are some family doctors that are experienced with seeing breast cancer survivors, and they have, time to spend to go through some of the mental health and physical health issues surrounding that survivor period. The Alberta Cancer Guidelines are a great resource. They're quite prescriptive. They lay out sort of what to look for, what you expect for treatments with different types of breast cancer. And then for young women with breast cancer, there are different challenges that I haven't really even delved into today, whether it's, freezing eggs to consider fertility down the road, having the body being put into menopause, and so bone health around that. There are just different concerns with young women who experience breast cancer. They have young families often, and the aesthetics of that, and whether they want breast reconstruction. So this resource I find is quite helpful for some of those needs. Thank you for your attention. I'd like to welcome any questions.
Thank you so much, Dr. Izeife. I wish I met you before I went through my treatment. Because you're so expert. Everything is so well explained, kind of like, I don't know if there are questions. I know we have a Q&A, and I'm trying to manage time. So, and I also do know that you would have to leave like at a particular time. So I'm trying to balance that. But I'm going to ask you two questions before we go to survivor story. And then Q&A. I will still ask you to please stay for the Q&A session for the panel. But there are two questions that I did notice. I know somebody was asking, so I'll ask both of them and you can just answer them in a few more minutes. Somebody was asking, what is lymphedema? I know you did mention it a little bit, but I guess they missed it. Another person was asking, and actually I did write it down and I was going to ask, because I know somebody who's very young who's going through breast cancer, and a very aggressive one. So it's the fact that you did talk about the use of Lupron in younger women. So, okay, so the care is for younger women who undergo the treatment, making her body go into menopause, like you said. They are able to have kids in the future. Actually, I was going to ask you because I've used Lupron before, not even when I had breast cancer, when I had my hysterectomy. And I know that it was for a short period of time. I did go into kind of like menopause. I had all the signs, but then I went back because at the time I still had my ovaries. So I wanted to ask, so please go ahead with those two.
Yes, yeah. So for this question here, so for lymphedema, sorry, I didn't actually go into more detail on it, on what it exactly is. So lymphedema is swelling of the arm where there was surgery in the breast. Because what happens is a surgeon removes a breast tumor and removes 1 or 2 or 3 or sometimes more lymph nodes on that same armpit. And our lymph nodes, as I said, we have thousands of them in our body. And what our lymph nodes do is they drain excess fluid in our body. We all have excess fluid that our body's always making. And the lymph nodes help us not all to be swollen because they drain that fluid out and put it in our bloodstream so that we can pee it out. So what happens when a woman has had some lymph nodes removed from their armpit is that excess fluid now cannot drain out of the arm very easily, and it accumulates in the arm. So I had a picture there in my slideshow where if you compare the two arms, the arm that is affected by lymphedema is more swollen. And I've seen, lots of patients, I would say about 50% of patients in my clinic have lymphedema, and the arm is quite swollen. And comfortable because it's pushing on the skin, it's stretching the skin is tight, it's painful, and this is a serious and important side effect to note from surgical treatment for breast cancer. So now they have compression sleeves that we use to help manually move some of that fluid into the axilla or into the armpit so that it drains out. And then the lymphedema experts in that lymphedema clinic, they will offer, warm compresses. They teach you kind of how to massage the arm. I know one of my patients said that they sat down with her and went through the technique of massaging the arm sort of at night when you're watching TV or something, how to massage that fluid and encourage that fluid to mobilize into the armpit, which is ultimately how it gets drained out of the arm. And so for young women, for the next question, for young women who are going through breast cancer treatment and their body was put into menopause. So chemo can put the body into menopause. And what happens is that chemo's putting the body into menopause can sometimes be temporary, but sometimes it can be permanent as well. So in the women where it's temporary, what happens is that after chemo is done, then they will get their periods back and they resume their menopausal cycles. But as I said, we use this Lupron drug accompanied with an aromatase inhibitor like anastrozole or letrozole or exemestane. We use Lupron with one of those drugs to increase the chances of curing the woman's breast cancer by putting the woman's body into menopause. And, you know, a lot of women are interested in still conceiving after completing breast cancer treatment. And this is certainly possible. We just like to recommend that they stay on anti-hormonal treatment for about 18 months. And that's because research trials have shown that women who can stay on anti-hormonal treatment for about 12 to 18 months, they really can lower the chances of the breast cancer coming back in the long term. So I try and recommend my patients stay on. You know, I have several young patients, and I try and tell them to stay on for at least 18 months. And then after that, after you've gotten at least that 18 months of blocking the estrogen in the body, being in menopause, then you can come off those drugs and the cycles will resume, and we can think about conceiving at that time. And usually these are women who would have frozen their eggs before starting chemotherapy.
Thank you. Thank you so much, Dr. Doreen. Thank you so much for that. I like the explanations. There are other questions for you, so please don't go away. But I'm going to take a break from that question. We'll come back to Q&A session. I'm going to introduce two people. They are survivors. They are also professionals. So I'm going to let them speak for 10 minutes each. I'm really big on time, so I'm monitoring this. So please pardon me. So there are two people. I'm going to just introduce them together, and I'm going to let them go back to back. I'm going to ask them if they can make it 5 minutes each. I know they have a lot to say, just because I'm looking at the time, and I really want us to end this on the dot of 6. And I know that with questions, there's a lot. So I'm going to introduce Mrs. Yinka Marcos. I call her Auntie Yinka Marcos. Before I say anything about her, actually, she was one of the first people that I told when I was diagnosed with breast cancer. I remember she came right to me in my room then when I was still crying and didn't know how to navigate this process. So thank you. She's a certified professional counselor. I have also done some counseling with her professionally before. So I'm really happy to introduce her. She's a member of Professional Association of Christian Counselors and Psychotherapists and Canadian Counseling and Psychotherapy Association. She does own Open Life Counseling Ministry in Calgary. She's a parent and a co-author. Walk with me, a journey through life, hardships, and joy. That sounds like me. Okay. Her passion is in supporting individuals and their families resolve personal and relational challenges towards emotional wholeness and better relationships. So if you want to book an appointment with her, do www.hopealiveministry.ca. She's, most importantly today, alive. She's a breast cancer survivor. And I'm going to introduce Mrs. Florence O'Mara. I would love to call her a senior colleague. Okay, she's a social worker because I am too. She's a registered social worker with Alberta College of Social Workers. She's been in this field for over 20 years, currently working as a social worker with Alberta Government, Child and Family Services. She also works as a medical social worker at the hospitals in Calgary. She works in emergency, maternity, ICU. She holds a bachelor's degree, a BSW. She holds a master's degree, MSW, both from the University of Calgary. She's currently the vice president of the Oladile Foundation. That's why we're here. She's one of the people making this happen. She's also the co-founder of African Cancer Support Group. Again, while we're here. And again, most important to me, she is a survivor too. So we have too many things in common, like unbelievable. Okay, so we're gonna listen to, I'm gonna give you both 5 minutes each. Please keep to time. God bless you.
Okay. Who is starting?
Auntie Yinka,
can
please go
start.
ahead.
All right. So at some point in my life, I was told that I have dense breasts. And it was quite interesting. Just trying to get my, okay. And so I was going in for mammogram as many of you do. And of course, mammogram will show a lot of things. And so that's the good part of mammogram, I guess. And I continued my mammogram for dense breasts. It shows in the mammogram as a tissue that is has more fatty tissue, you know, like the dense breast has more fatty tissues than the non-dense breast. And so it just appears in that mammogram as solid white area in the mammogram when they show the picture. And so I continued. Well, it was nothing about, okay, this is going to result in anything, and I didn't think anything of it. So at some point again, I continued mammogram, and 1 year they detected a cyst, and the cyst is right there. It has fluid in it, and so what happened was they extracted the fluid. It was benign, was okay, and that was good. Many people with dense breasts would have maybe at some point some cyst that they have to drain the fluid. So mammogram, that's the power of mammogram and ultrasound. It's really important as someone with dense breasts to do that, to take mammogram very seriously. I mean, everybody should. Anyway, continued yearly mammogram, and 1 year diagnosis happened. It was really devastating. It was traumatic for me. It was, I experienced grief about it, some emotions, despair to rage, shame and guilt. I should have done this. If I had done that, this couldn't have happened, and all that. And God, no, why? You know, all of that happened, and it was really, really something. But the treatment that I went through is the lumpectomy, chemotherapy, lots of it, and radiation therapy. I remember under the machine of the radiation, I was always reading Psalm 23, which says I'm lying down. So I'm lying down in there and imagining being in a green pasture. He leads me beside quiet waters. He refreshes my soul. He guides me along right paths for his name's sake. I walk through the valley of the shadow of death. I will fear no evil. Your rod and your staff, they comfort me. And I read that throughout that. I finished my radiation therapy when I was on my the day before my 49th birthday, which was really interesting. So all that went on, and it was just the emotion that would come in and out and all that. And God factor was huge because I had a lot of private cries. You know, even when people come, they go, and when they go, you had your cry. And so I had my cry. And one of the days I was having my real cry to God, and I was holding the Bible and saying, okay, God, just comfort me. I need comfort. And he says, come to the place of praise. And I was like, yeah, place of praise. Praise you for what? For doing this? And anyway, we had our conversation and it went really okay. And so I learned how to come to the place of praise. One of the things that that happened in that place of praise was I could either stay down or crawl up. That's my slogan then. As I lay down weak and fatigued and all that, I was thinking I could stay there or I can crawl and get up. So I decided to crawl and get up. So I would get up and do some dance and do some good Zumba. Until now I do Zumba, and it's really interesting. Then I went for counseling for my for the grief work. Those who do counseling will know that there's grief in a lot of things we go through, and so I went through just walking through the grief of the treatment and of the slowing down the emotions of guilt and shame, the emotions that's going up and down, and also the grief of knowing that, okay, I may never be the same again. And then at that point, I was actually starting my private practice in counseling, and I was working in the church, working for the Lord and all that. And so all of that was giving me grief, because I thought maybe I wouldn't be able to do all that again. So the counseling really helped me to get through things, and I had to make a list of my self-care. So I decided, okay, I'm going to go in the bathtub and soak in the bathtub with music and all that, and it was great doing that. Asking for help. I'm not one to ask for help, but I learned God said, you have to ask for help right now, because you are helping everybody else. Now it's your turn to be helped. So I began to ask for help. Can you do this for me? Can you go for groceries? Can you do this? Can you cook? And, you know, even asking my husband for help was a growth thing for me. The place of praise was really something, because during that time, I didn't want to praise God for sure, but then God led me to some scriptures, and he gave me a lot of scriptures that I personalized, and I have the whole list of those scriptures, and I read those scriptures every single day, at least 3 times, and I would read them. There were like 3 pages of it, read them over myself every day. So then when I read them, I would just praise and dance and go back. And a lot of times I get lifted with that. A lot of people prayed. A lot of people were so supportive. My doctor was great, just helping me through the physical part of things and the biological part of things too. So it was good. Eventually, at the end of it, I don't know if everybody knows that you can get your whole full notes, the doctor's notes from AHS. It was amazing. They gave the photocopy everything from beginning when I was doing dense breast and all of that till the end of my treatment. So I have those notes, big bundle of notes. And one day, some years after that, I completed my treatment. I had a good read of it, and it was interesting to read your notes. Oh my, they said, oh, this lady, she's strong, she's this, and the doctors, it's amazing what doctors write in their notes. And it was fun read at that point. And so, yeah, so that's my story of the diagnosis, the treatment, and how I came out of that. Thank you very much. So today I help people who are going through treatment with grief work around cancer surviving and treatment. Thank you.
Thank you so much, ma'am. God bless you. So I'm going to go straight on to Mrs. O'Mara. You have 5 minutes.
Okay.
Thank you, ma'am.
Oh, hi, everybody. Again, my name is Florence O'Mara, and I'm a social worker with the Alberta government. I went in 2017. I had a very bad year. I lost my son in March. Then I stayed home from March to July. Then I went back to work, and I remembered I needed to do my yearly checkup. So I went to the doctor, and the doctor said, okay, we'll check you, we'll do the blood work. And so August 15th of 2017, I went for a mammogram because of my age. On the 17th, I was called back, and I'm like, I was telling my husband, they better be kidding, because my doctor had just left for Pakistan. So I had to see a male doctor. August 25th, he called me. I was told to go back to see him. So I went and sat in the doctor's office, and this doctor comes in and looked at me and looked away. And I'm like, oh my God, this is very scary. He's like, do you have any history of cancer in your family? I'm like, in Africa, I said, I grew up in Africa. Nobody talks about diseases of older people, but I know only about malaria. Actually, he burst into laughter when I said that. But anyway, to make it short, he's like, you have breast cancer. And guess what? He walked away, left me crying in the office. So I cried a little bit. I came out, and I decided I don't want anybody in my family to know that I have breast cancer. Although before I went to see the doctor, had told my husband, boil me eggs and make me a cup of tea. I have to go after this doctor's appointment. I'm going to the office. So that's exactly what happened. Instead of coming home, I cried so much. I drove straight to Peter Lougheed, because that day I had a shift in the afternoon at 3:30 at Peter Lougheed. So I went and cried in the car until 3 p.m. So I went in, closed the door when I entered the office in Peter Lougheed, and I knelt down and I said, God, you are not going to, I can't believe this is happening to me, and do me a favor. I don't want anybody calling me on a pager, because you need to talk to me the next 8 hours. That's exactly what happened. There was no pager, and I cried my head off. Then my husband called me about 11 p.m. because the shift ended at 12. He's like, you didn't come home. I'm like, no, I'm okay. I'll talk to you later. So anyway, to make it short, 3 days later, when I was called, and the doctor talked to me, this same doctor talked to me that you are going to get a phone call from a nurse, from a surgeon, and whatever. And we went and saw the surgeon about 5 days later. So then I was given the day for my surgery. Of course, I went for surgery September, I think 7th. And surgery went well because they just removed the cancer. So it was just, because they said it was only 2 centimeters. So it was very small. They're like, we're just going to pull it out. That's the word the doctor used. I'm like, pulling it out? He's like, no, I'm just joking. So anyway, they removed the cancer. 7 days after that, I got up at night to go to the washroom, and my breast had swollen. It was touching my neck up, actually my cheek. So the next day, my husband asked me to the hospital. They opened it and they removed pus and blood, 1.5 liters. So the doctor said, you know what, we are not going to close this wound again. You'll be having a nurse come home every day in the morning and the evening. So it was the hardest time because my son cried every day. My daughter cried every day. So anyway, then I started anastrozole. It went very well. I was given anastrozole for 5 years. So this is my 4th year. I have no complication. I take only one pill a day, and I'll be done if all goes well. At the end of next September, next year, it will be done. So I also did radiation 32 times, but up to now, under my armpit is so dark, you can't even believe it. So I am happy to hear that after treatment, it will be better, but I have a very dark armpit. I don't sleep well. I used to sleep very well. I don't sleep very well. And you know what? What helped me so much was a group. And Sister Yinka, who is online, and other girls came and rescued me. They started this prayer group, I think May of 2017, because I'd just lost a son too. So these girls prayed for me so much. I had this cough. Even during the treatment, Yinka prayed personally for me about this cough. But eventually the whole group prayed for me and the cough went away. So what I want to say about my journey on this, it's the best thing anybody can have is have friends like Yinka's group, because they were there 24/7. I would call Yinka all the time. I call her my doctor. I would call her anytime and cry, and she was always there. And I had other friends. This journey was very hard because this is what I heard during this. My community was like, you breastfed your kids, you can't have cancer. This is a lie, this is fake. So I am very glad that we have this group now, that we have doctors who will tell us exactly what they know, instead of people just saying, you know what, when you breastfeed, you don't get cancer. I just want to thank this group so much.
Thank you so much.
Yeah.
Thank you so much. God bless you. Thank you for that. So that's interesting. And it's always good to listen to survivor stories, because every story and every journey is unique. There's no two experiences that are exactly the same. You know, some people have issues with, you know, the mental health after cancer. Some don't. Some, I had all my lymph nodes taken out. Didn't have any lymphedema. So, I had tamoxifen for 5 years. No, I didn't react in any way that I know to tamoxifen. But I know people who couldn't take tamoxifen and they had to stop. So every story is different. It's always good to connect, just figure out what's going on with you, what you need to do. One of the things that is usually ignored is the mental health aspect, the grief, the loss. And actually, I wanted to add that it also does affect every member of the family, not just the survivor, not just the patient. I say cancer takes away so much, it affects everybody. So nobody should even be ignored. The family should be carried along. Everybody should get help if they need help, especially with their mental health. I know we don't have time. Dr. Doreen, I hope you are here. Dr. Fajita, please be here. We're going to answer these questions together now. We need your help. And Dr. Doreen, I just want to make a request. Auntie Yinka and I were saying we do need a follow-up to this, kind of make it a lot more question and answer based, and one that you can explain some of those terminologies. It would be really, really nice. So please keep us in mind. We're going to do a follow-up on this one. Okay. So let's go now. We're going to answer the questions. Thank you. So if you still want to ask questions, please go ahead. You can chat it. If we don't get to it today, we'll get to it anyways. We're going to have a full session of a follow-up on this. We already answered this question. So please let's go to the next question. Next question on the slide. Okay, while that's going on, I'm just going to ask a question that is on the chat. Somebody said, I experienced some tingling during chemo. Now 9 months after chemo, the tingling is worse and has spread to the entire hand. I also experienced pains and needles that are very uncomfortable. The lymphedema clinic and my oncologist don't seem to know what to do. Is there any other advice? I'm going to ask us to please answer this question in 1 minute. Just straight on. We will elaborate on a follow-up time. So is there anything else that she can do, doctor?
Sometimes, sometimes the numbness and tingling from chemo can go on forever. So it can be permanent sometimes in about 30% of people. We always say the 30-30-30 rule, where 30% of people it'll recover completely, 30% of people it'll partially recover, and 30% of people it'll stay the same forever. I would recommend, sort of your non-pharmacologic procedures. So warm compresses and, exercising the arm, whether it's yoga or Pilates, stretching maneuvers as well. And then the pharmacologic stuff, so the drugs. So I give a lot of people gabapentin or pregabalin, the drugs that help with the nerve pain. And then I would ask if they have done extensive investigations to make sure there's nothing else going on in the arm. So sometimes what might be worthwhile to see a neurologist, like a nerve doctor, to see whether they have any other recommendations and whether they can do a nerve conduction test to see how the nerves are.
Thank you. And follow up to that, she's had 2 mammograms a few months ago before diagnosis that showed dense breast and nothing else. And then a biopsy diagnosed the cancer. She's saying that now the oncologist wants her to keep doing annual mammogram and ultrasounds, but she's saying that she's not convinced that they are beneficial. I guess the reason why she's saying that is because they didn't detect anything in the first place, and it was just a biopsy that did that. So she's probably wondering why. Happened to me too. I still do it. I think I should continue to do it. So I guess any of you can answer that, why she should keep doing the mammogram. 1 minute.
Okay. I don't know, Dr. Fagita, maybe I'll start and then you can add anything if you want to add something. Okay, so yeah, I get this question a lot. I think it's based on guidelines. There actually is no indication to do anything other than a mammogram for screening in people who do not have BRCA1 or BRCA2 or any of the other familial breast cancer predisposition syndromes. So people who have BRCA1, BRCA2, or any of those other familial predisposition conditions, we say do MRIs of the breast. But if you don't have that, then we still say mammogram, even after a breast cancer diagnosis. I would advocate for yourself and suggest maybe a mammogram ultrasound, because that can show more than the mammogram. See if they will do that. I would do that for my patients, and I would recommend you request that if you could.
Thank you.
Absolutely. I agree with her. Yeah, I agree with her. That's it, because whatever your oncologist is saying is based on evidence. It's not guesswork. So it's based on the literature. So I would strongly recommend that she follows their recommendations. And yeah, if she can get an ultrasound, that would help too.
Thank you.
Mhm.
I tell myself the doctors know better than me. And they may not be, they're not God, but they know this is their job, and I better listen. If they say it's necessary, I think it's a better option. In that way, I would say err on the side of caution. At least do a mammogram. It's not, do your ultrasound. It won't kill. Thank you. We're gonna go to the next question. I'm trying to hurry. Just 1 minute. Can we have the next question? Any other question there? Somebody was asking actually if there, Dr. Fagita, somebody was asking why there's so much side effects to the drug tamoxifen, letrozole, and why they take them after chemo, surgery, and radiation treatment.
I think I'll defer to Dr. Izife on that. She's the expert around this. So if you don't mind.
I'd first like to start off by apologizing for all the side effects from these drugs. I always tell my patients, I'm so sorry. I made you feel so miserable. Yeah, the reason we take these drugs is to block the effect of estrogen in the body, because estrogen acts as food for certain types of breast cancer. So the luminal A or luminal B subtypes of breast cancer, estrogen acts as food for those types of breast cancer. So what these drugs do is they block estrogen in the body, so the body does not see estrogen. So there's no estrogen hanging around acting as fuel for potential breast cancer regrowth. So that's why we give these drugs. You know, the majority of my patients, I would say 60 to 70% of people have no side effects, and they're like, are you sure you're giving me the pills and not a sugar pill or a placebo? Honestly, but you know, there's the 20 to 30% of people that do have side effects. The vasomotor or the hot flashes are the most common, bony aches and pains, and it tends to be like a stiffness. Yeah, those can be quite discouraging. I would say the side effects are worse in the first 3 months and they get better after that. I would also recommend switching from one AI to another. So if you're having a lot of side effects with letrozole, try anastrozole or exemestane, because although they sometimes have class effects, I do find that some people, they hate anastrozole, but letrozole went okay, or vice versa. We do see that. So a lot of us will switch from one to the other. And then other things, if worse comes to worse, if you've tried all of the different AIs, tamoxifen, and you're still having a lot of side effects, the last thing I would recommend is, you know, switching, taking it every other day, or, you know, taking some time off and just like letting it wash out of your body and then trying it again and then taking it every other day. And I do have some patients who take it every other day, and that's the best they can do. And I tell them that's better than nothing, honestly.
Thank you. Thank you so much for that. Actually, those side effects, I didn't have it, but then I had something really weird. I did radiation, and then I had, my skin was just peeling on my bed. Like I'm sitting down, my breast was peeling out, literally my butt, like, and I had radiation for 6 weeks. It was so bad. And then my breast was looking like I was just depressed and all of that. So I think, but then I'm surprised that after like 6 months, everything came back normal. So, you know, we will get better. I guess it's just a phase. I think we're done with the questions, except somebody has something really burning. There is the survey on chat. Please click on the survey, fill out the survey, very important, so we know how things are going and what to do. Somebody did ask though that, can somebody with heat edema access the lymphedema clinic? Dr. Fajita, you know,
I doubt it. That's a specialized clinic for patients with lymphedema. Heat edema is slightly different. And so if you have concerns around that, I'll recommend you see your doctor so that they can do some workup for you and then give you the appropriate therapy. I don't think any patient can just walk into the lymphedema clinic because they have edema. Am I right, Dr. Izife? Yeah.
Yes, that's, I don't even know what heat edema is.
Okay, thanks.
That's just from salt retention and water retention and swelling.
Right.
Okay. So, and I'm going to ask everybody this question, everybody on the panel, including Auntie Yinka and Mrs. O'Mara. So somebody did send me a message privately that, can they contact you? Can they, you know, you can be everybody's doctor, but can they contact you? I'm pretty sure with Mrs. O'Mara, Auntie Yinka, of course you can, because, you know, mental health, I'm very big on mental health. I know the doctors want to fix our body a lot, but mental health, I was very depressed. I had a lot of fatigue. I couldn't explain it. I didn't even know anything about fatigue at the time. I'm just, why can't I do anything? Why can't I do anything? And I'm really energetic. So it means a lot. And, you know, so contact them. But I wanted to ask the doctors, can they contact you? Can somebody contact you?
I mean, for me as a primary care physician, I believe that you need to talk to a doctor that knows you and that has your history. So it's always good to be registered with that doctor. And we always discourage double doctoring. If you have any general questions, I mean, feel free. I'm on Instagram. You can connect with me there. But I just feel it's neater that way, and even for the benefit of the patient. I run a practice from our bedroom, and unfortunately, I'm not taking on any new patients. But if you have any burning questions, I'll be more than happy to help you. But what's much better is that you have your own home doctor or home family physician that knows your history, that has that information, and that can provide the best service for you. Thank you.
Thank you.
I would agree. I'm happy to answer general questions. I'll do my best. It's I get over 100 emails a day, so I really try and keep up, but it's difficult. But I will certainly, I know I prioritize when Yinka messages me, I try and look because I know it's important, but it's tough, you know.
Yes,
Thank you.
if I can say something, I know I'm not on the panel. I know people contact me privately and they have some questions. Once I know who will be able to answer, I know I check on Doreen. I just message her if she's okay. Sometimes she's on holiday. She say, okay, I can talk to the person. So if you are listening on this platform and you want to reach out to any doctor, just get in touch with me and I'll be able to see who'll be able to talk to you.
And then the other thing for me, I always post a lot of women's health videos on my Instagram handle. So you can always follow me. And funny enough, in November, I'm talking about boob banter. So we're going to be talking a lot about breast health. So that's just something to watch, just for general information that for yourself and that you can also share with your friends.
Yeah, and if you can send us the link, we'll send it to the database.
That's awesome. Thank you so much. That's what I would suggest. Get in touch with the African Cancer, call Auntie Yinka Oladele. She would connect you to the right person. If you need, like Dr. Fajita said, she's not taking new patients, but if you do need a doctor, contact her too. There are ways around it. We can get you another doctor. We can get you somebody else. If you're worried, call Auntie Yinka, call Mrs. Amara, and call me too. We'll find a way around it. There's always a solution. Okay. Thank you so much, everybody. Thank you so much, our panelists. Thank you, Dr. Fajita. Thank you, Dr. Ezeifa. Thank you, Mrs. Marcos. Thank you, Mrs. Amara. Thank you so much. We're going to close shortly. I'm going to let Auntie Yinka Oladele give us a few announcements and we'll be done in a few moments. Please stay on with us. We'll be done in a few moments.
Okay, thank you, everybody. Like was said, we have a counseling services that we can provide to you. We have counselors among us that talks about mental health. We actually have 2 qualified and registered counselors in our midst in the group. So we are here to help. This is the first African Cancer Support Group in the whole Canada. So please reach out to us, and it's not just for one type of cancer, is for all types of cancer. We are all here. And also we have someone who does a health coaching. We have health coach that can help you during your journey. Please reach out. We are here. My phone number will be in the email that will be sent out. Also, like Pastor Bola said, we have a feedback form that has been sent out. It's in the chat. We also will send it to the email for those that are registered. You will get it. Please, we need your feedback. And if you know anyone going through the journey, whether it's survivor or patient, or if you are going through cancer yourself, ACSG is here for you. We'll also be sending the form to you as well. Also, we are not-for-profit. So if you like to donate, our website is at theafricancancer.ca. I would like to receive any donation if you like. Thank you. Pastor Bola, go ahead.
Thank you. Thank you so much. So we're going to close with prayers. We're going to pray. I wanted us to spend 10 minutes, but we won't. God is not limited by the number of minutes anyway. He hears us, but we're going to pray. We're here because God has kept us. We're here today because God has kept us. Ultimately, I have over almost 3 decades supported cancer patients before I was diagnosed with cancer. That's why when I was diagnosed, I'm like, why? Me? No, can't be me. I have seen cancer patients pass on, you know. I have seen people recover and different stories. We are here today because God has kept us, you know. He just wants us to be here. And so I want us to just thank God for being here. I want you to thank God for being here. You're online, you're not diagnosed with cancer, you're not, you don't have the illness. Thank God for you. Thank God for you. Everybody has their journey. Thank God. I want us to thank God. I believe very much in the power of prayer. So I want us to pray for one another. There's so many people among us online today in this group that are currently struggling and battling cancer. So many people right now are battling with this disease. You know, I want you to pray for healing for them. I want you to ask God to touch them. When somebody is suffering from cancer, as I said before, they suffer all manner of things. You suffer even, you know, where women here, your sex life suffers, your relationships suffer, your children suffering. I remember when I was passing through I would just see my children, you know, I thought my home was very happy. They would be tiptoeing. I'm like, no, this is not good. I want you to pray for every member of the family of people going through cancer at this time. I want us to ask God to help them, send them help, touch their lives, heal them. Healing is ultimate. Healing is ultimate. It's so good to walk into your doctor's office one day and the doctor say you are cancer free. I want us to pray that as many people online, as many people in this group, in this community that are currently going through this disease, that the hand of God will touch them. There is healing. There is healing. There's healing. There's medicine and there's healing. You know, they don't contradict each other. God gives the wisdom. I want us to pray. You know, I was talking today, earlier this morning with Auntie Inka, and we were talking about even being in Canada. If you're in Canada, I know there are people actually watching who are not in Canada today. The people that are watching from UK, the people watching from Nigeria, anywhere you are, you have access even to this information. That's a privilege. That's a privilege. I want us to pray that people will get the help that they need. Sometimes it's just information. Sometimes it's just the right link. I remember as I walked into my doctor's office when I was diagnosed, the oncologist, he said, you don't have cancer. Who even told you? I've not even, don't worry yourself. Like he just removed all of my fears. Like he just made it look like it was nothing. You know, just even getting the right doctor. I want us to pray. I want us to pray. Just getting that right word, getting the right information. I want us to pray that people will be connected to the right source, the right doctor for them, you know. I just want us to pray. I want us to pray, you know, that people, this is a place I remember when I used to pass through Cotambeka in years ago, I'd be like, you know, but when I went there, I was blessed. People helped me. They were good to me. I want us to pray. I want us to pray, especially for people who are not even, you know, in Canada. Maybe they don't have access to such high level of medical care, that God will help them. God will help them. God will provide resources for them to be able to go through this period, that the Lord will give them finances. I know somebody right now, you know, going through this journey, and there's even no money for treatment, right? There's no money to even do the treatment. The places she's been referred to, she cannot go there. I want us to pray. So finances is a problem. Everything kind of suffers. You know, I couldn't work at the time. I had to quit my job, actually, to do treatment because I didn't have the necessary insurance at the time. I just started a new job and all of that. So many things happen to people. I want us to pray. I want us to pray, you know, for resources. The Bible says God owns 1,000 cattle upon the hill. The resources for them to be able to, you know, live a quality life. There are people that are at end of life. They need to have all the things that they need. I want you to pray. I want us to pray for people who are struggling. One of the things that happen is grief. You begin to doubt. You are even doubting God. I want us to pray for people's faith to be elevated. I want us to pray that their faith may be elevated. The Bible says David encouraged himself in the Lord, that people will be encouraged today, that the Lord will soothe their heart in the name of Jesus. As we close, I want you to pray, and I want us to pray for people to be touched. People to be touched. There's something that as a prayer I like to share with us. I pray this prayer. I say, you know, my body is a temple of the living God. My body, this body of mine, even though it is flesh, it is God's temple right now within me. And this body cannot be sick. I want us to pray for everybody, every one of us. Even if you're online, you are not diagnosed with anything, your body will not harbor cancer in the name of Jesus. And lastly, I want us to pray, concerning that. I want us to pray against that name cancer. The Bible says there is a name, I address cancer. I address cancer. I personify it. I address it. I said, cancer, you are a name. And the Bible tells me there is only one name that is above every other name. That at the name of Jesus, every knee must bow. And so because cancer, when cancer comes into a family, into a life, it begins to behave like a god, begin to control what you do and what you don't do. It begins to limit your movement and the things that happen. I want us to pray. There is only one name. Cancer must bow to the name of Jesus Christ. So everyone under the sound of my voice tonight, I decree and I declare unto you that cancer cells in your body, as you hear my voice, run out of your hiding places in the name of Jesus Christ. You will not prosper in these bodies in the name of our Lord Jesus Christ. I decree healing unto you. You must be healed. You are the Son of God. The Bible says no man shall trouble you. Father, we thank you. We give you praise. Let's bring our prayers to a close. Thank you for this time. Our God, the things we haven't said, you know them. You know them. You know the sufferings of your people, oh God. Stretch out your hand of healing. We decree, as we have spoken in your ears, oh God, let it be done unto us in the name of Jesus. Blessed be your name, oh God. In Jesus' name we pray. Thank you so much, everybody. Thank you so much. Father, we thank you. We give you praise. We give you praise. We give you praise. Thank you so much. We're going to close now. We're doing good. Not too much, just a few moments above our time. We are going to unmute ourselves. Unmute ourselves. And you are going to put on your camera. We want to take a picture. Please. I usually don't like when they say put on your camera, but don't worry, it's just gonna be a minute. Just put on your cameras, please, and we're gonna take a quick picture, and we're gonna just close. We're gonna take our grace, and we're gonna close. Thank you so much, everybody. Is everybody there? And Tinka, can we take the picture?
Yes, sure, done.
You done?
Yeah.
Okay, I'm gonna do a screenshot too and send to you. I see
you.
you're using your.
Yeah, screenshot is better than now.
You're using.
Okay, I just did screenshot. Okay, send it to me.
So let me try and see if I can do any better. Send it to you. Thank you, everybody. Let's just say the grace together, if you don't mind, and we'll close. And the grace of our Lord Jesus Christ, the love of God, and the sweet fellowship of the Holy Spirit be with us now and forevermore. Amen. Thank you so much. Join us again next. We're going to send you all the information. We're going to do a follow-up. Thank you for calling in tonight. God bless you. Thank you.
Thank you.
Thank you.